Hi, this is Amanda Wood and welcome to the Restricted Practices Training. This will be a brief version of Restricted Practices Training aimed at supporting behaviour support practitioners and people who are entering into adult disability support services and providing some kind of therapeutic or behaviour support to people within the services. We're going to talk about what restricted practices are, where they come from, and how you can identify them, and just some other issues around restricted practices. Okay, so let's get started. What are they? So restricted practices, at the point of recording this, come from ADDIC behaviour support policy. With the closure of ADDIC recently, it is believed that the guidelines around what is a restricted practice will be picked up by the quality safeguard framework that's coming from the NDIA. However, they are only in draft format at the moment, but it is highly unlikely that anything will significantly change around the use of restricted practices. So they are practices that limit, restrict or control someone's behaviour. So they're strategies that might be put in place in day services, group homes, or maybe even in other environments that are limiting or controlling a person with an intellectual disability's behaviour. In many cases, they may be considered a breach of human rights and civil liberties. So when we talk about things like physical restraint, then it's definitely touching into the area of breaching a person's human rights, freedom of movement. So they're quite a serious and significant strategies to put in place, and we'll go through what there are different categories of them. Just to give you a bit of an outline of the history, in the 1900s to the 1970s in the disability sector, what we call restricted practices were used regularly, and they were considered necessary and normal. So, for example, it was common practice to put a person with an intellectual disability, lock them into a locked institution, give them chemical restraint medications, and often use things like straitjackets, tying them down to beds. And these practices in that era were considered necessary, they were common practice, and they were considered normal. In the 1970s to the 1980s, there was a real shift in society understanding and what was considered okay in supporting people with a disability. So at this time, there were still many people going into institutions or what later were termed large residential services was seen as the normal for someone with an intellectual disability. But we started to move into an area of teaching. So this is the area where skills development and task analysis were the buzzwords. Still, most people with an intellectual disability were heavily medicated on antipsychotic medications, and physical restraint was a very common strategy. And I think it's safe to say that in these times, chemical restraint medication and physical restraint were pretty much used on everybody with an intellectual disability in an institution. They were overused, and there was no need to justify their use. The justification was that, well, the person has an intellectual disability. In 1987, something called the Guardianship Act came into place, and now known as the Guardianship Tribunal. And this outlined that restricted practice, there were certain things that were restricted and shouldn't be used with a person with an intellectual disability, or they needed specific consent avenues, somebody to consent on the person's behalf. And the Guardianship Tribunal is a branch of the Supreme Court that implements the 1987 Guardianship Act, which has had some amendments since then, but largely their role now is to determine, first of all, whether a person with an intellectual disability, and they also support people with dementia and other disabilities that affect their cognitive capacity, whether that person is able to consent on their own behalf. Do they understand that they're agreeing to take, an antipsychotic medication and what an antipsychotic medication is? So the Guardianship Tribunal, a branch of the Supreme Court, are responsible for doing that. So let's look at some of the viewpoints around restrictive practices that are common today. The Australasian Society for the Study of Intellectual Disability have an official position statement about restrictive practices, and that is that they are unethical and they are inconsistent with human rights. They also state in their position statement that it's a cause of physical and psychological harm to the person being restricted and also to the person who has to apply the restrictions. So they're saying that putting a restricted practice in place is not only possibly physically and psychologically harming to the person that's being restricted or restrained, but also to the staff that are having to do that. So that's their viewpoint. ADIC, the Aging Disability and Home Care body that is now being dismantled due to the introduction of the National Disability Insurance Scheme and Agency, their viewpoint has been that people with a disability have the same rights and responsibilities as everybody else, and that the services that support people with a disability need to promote quality of life, uphold dignity, and safeguard the rights of people with an intellectual disability. So as a therapy and behaviour intervention and support service, Real Therapy Solutions certainly takes on that same viewpoint, that it is our role as therapists supporting people with an intellectual disability to promote their quality of life in everything that we do with them, uphold their dignity and their rights through the work that we do, and to respect that, particularly with adults, that they are over the age of 18 and that the law has the viewpoint that anyone over the age of 18 has the right to make their own decisions unless they're deemed incapable of doing that. Now, the Guardianship Tribunal is one of those places that may deem someone is not capable of doing that. But even around that, we need to be making sure that we're giving the person as much information about what the practice is and what we're doing and what the options are, and helping them understand that process, even if they have a substitute decision maker. So let's have a look at what restricted practices are. As I mentioned earlier, most of them are a breach of human rights, not all, but most. Some can also be considered criminal without appropriate consents and authorisations. So that's a pretty significant statement to make. But when we look at things like physical restraint, holding someone down when they don't want that, may be considered criminal assault. So we're talking about quite significant strategies here in some of these restricted practices. Having said that, though, they may be necessary at times. Certainly when we support people with an intellectual disability, many people have some quite significant challenging behaviours that come about for a variety of reasons, often used as a function of communication because they have difficulty communicating, and various other reasons. They may have had trauma, they may be in avoidance, they may have mental health problems. So sometimes in order to manage risks, restrictive practices are put in place. But we always need to remember that under that framework that they can be a breach of human rights, and in some cases can be quite significant and often border on being a criminal if without the right consents. So restricted practices are put into different categories. So these are the categories of restricted practices. We have exclusionary timeout, and we'll go through each of these in a minute. Physical restraint, response cost, or consequence-driven behaviour, as it's referred to in the quality and safeguarding framework. Restricted access or environmental restriction, as again it's referred to in the quality and safeguarding framework, and PRN, psychotropic medication, and seclusion. So they're all different categories of restricted practices, and we're going to go through each of those. So exclusionary timeout is commonly referred to as ETO. It's about forcibly removing a person from an area that's enjoyable or reinforcing for them. It's usually removing them from an area where others are or activities are taking place, and it's about not allowing them to return for a period of time. So this might be somebody's behaviour is posing a risk of harm to themselves or others, and the strategy is to remove them from that area. Now, it's important to remember here that asking somebody to move to another area, so, you know, John, let's go outside, let's sit down and try and calm down, is not a restricted practice, unless John refuses to go and you make him go. So a point to consider here when you may be coming across this strategy is, does the person actually believe they have a choice here? If the person does not believe they have a choice as to whether to leave or not, if you're using some kind of strategy, which is often physical restraint, in this case to get the person to move to another area, then it's most likely going to be exclusionary timeout and considered a restricted practice. So it's about moving them from an area that they enjoy, where they may be engaged in activity, to another area as a consequence of their behaviour. It may be to manage risk, and then you're not allowing them to return. So you might be locking the door, you might be standing in the way, whatever the strategies are, and we're saying, okay, the person can't return for a certain number of time. If you're a behaviour support practitioner and you're writing this into a plan, exclusionary timeout is something that you absolutely need to discuss with your supervisor when putting it into a plan. There are also there's specific guidelines around writing exclusionary timeout into a plan, and you need to refer to our policy on those. The other thing is the time frame. The time frame needs to be as minimal as possible. Putting someone into exclusionary timeout for more than 5 minutes would, for me, as someone who sits on restricted practice panels and a psychologist that's been working in the area for over 20 years, would set off some red flags for me. It's quite a considerable amount of time to put someone in ETO. Having said that, I do know of circumstances where that has occurred, but we're moving someone from an area that they're enjoying, that's reinforcing for them because of their behaviour and always because of the risk. It would be rare to put exclusionary timeout in place if it wasn't about the risk a person's behaviour poses. I can't think of a time where you would do that. And it's about not allowing them to return for a period of time. Seclusion is pretty similar to exclusionary timeout. The difference is that we don't let the person out until their behaviours have calmed down. So where exclusionary timeout is a time frame, seclusion is you're not coming out till you've calmed down. So it's about isolating someone, not allowing them to leave, maybe used as an emergency response, but always remembering that if a strategy is used more than 3 times in a known period, so not just in a year, not just in 5 years, then it's considered to be reasonably foreseeable that that strategy will be used again. So if seclusion has been used on someone once, then as a behaviour support practitioner or a therapist, you need to start looking at the fact that we may need to put this in the future. If it's been used twice or 3 times, then you definitely need to be assessing the need for that strategy with the person, the people around them, and any substitute decision makers if they are in place, because it's not considered an emergency response anymore. In seclusion, the duration in seclusion depends on the length of the crisis, so it's about when the person calms down. And we must always keep the person under continual observation. So line of sight, you can't put someone in exclusionary timeout or seclusion and just leave them there and not monitor them. They need to be monitored quite closely. As you can understand, it's quite a significant strategy. It's quite punitive at times, and would only ever be considered for risk management. I guess a good point to make about restricted practices is that using them because someone's behaviour puts them and others at risk still means that they're a restricted practice. So one of the most common questions I get asked is, or what people say to me is that, oh no, we used the strategy because it was a risk if we didn't put something in place, therefore it's not a restricted practice. And that is very, very incorrect. I'd say 99% of restrictive practices are in place because the person's behaviour poses a risk. That may be just justification to use it, but it's not a reason why it's not a restricted practice. So just make sure you're very, very clear on that, that most restrictive practices are in place because the person's behaviour causes a significant risk. They're still a restrictive practice, even though they may be deemed necessary. Physical restraint is almost straightforward, but one of the main things to remember about physical restraint is it's restricting a person's voluntary movement. So if we have a person who, say, has cerebral palsy and has some spasticity and involuntary jerking movements where they might move their arms, but it's part of their condition, they don't mean to move their arms, and a really common one is needing to put, staff members needing to put their hands on the person's arm while they feed them. Because of the spasticity movements, they may jerk their arms around and throw the food away, not meaning to do it. That's not considered a restricted practice. I would strongly recommend getting an occupational therapist to at least write some guidelines up around that and identifying that it's because of the involuntary movements and the spasticity. But under the guidelines as they currently stand, that would not be considered a restricted practice. So physical restraint is voluntary movement, restricting someone's voluntary movement. It may be by physical force, so it may be by holding someone's arms down. It may be the extreme of physical force where we're using physical restraint. It might be by using devices or materials. So that, for example, would include things like putting someone who's in a wheelchair, putting their tray top on to prevent them from getting out of the wheelchair. That would be considered a restricted practice. Putting the tray top on so that they could participate in craft activities or eat a meal would not be considered a restricted practice. But when you leave that table on there for the purpose of not allowing them to get out of their wheelchair, it becomes a restricted practice because you're restricting their voluntary movement. Things like arm splints, mittens, things over hands to stop people self-harming are considered a physical restraint strategy. So the common equipment and devices that are used that may be used as a restricted practice are things like lap belts, so strapping someone into a wheelchair to prevent them from getting out. Now, lap belts are also used to assist people who may have poor muscle control or tone, who tend to slip out of their wheelchair. That's not considered a restricted practice. So it's for the moment that the purpose of leaving a person in there so they can't get out because they want to get out, that's when it becomes a restricted practice. Things like bed rails, again, are commonly used when people suffer from epilepsy to prevent them from falling out of their bed during the night. But the moment you use it because someone maybe has a history of wandering or it's unsafe for them to get out of bed at night and you're putting that restraint in place, then it's considered a restricted practice. A better option for those kinds of things is just maybe a little alarm on the door or something that gives an auditory response to let staff know that the person's up and about and moving. Water chairs, again, are big chairs that people can sit in to relax. If they're left in there and can't get out, and you put them there because you don't want them wandering around because you're off doing personal care with someone else, again, that's considered a restricted practice. So when they're used to control behaviour or movements, they're considered a restricted practice. The other thing that's considered a restricted practice is seat belt buckles. So in New South Wales, as it currently stands, even though the law is that everyone in a vehicle is required to wear a seat belt, many of our clients don't understand, first of all, why they are strapped in a vehicle, the safety reasons about that, and they will try to take that seatbelt off. If a client is removing their seatbelt and other strategies such as looking at where they're sitting in the vehicle, giving them things to occupy and entertain them in the vehicle so that they don't get bored and want to take their seatbelt off. If those things haven't worked and the person's still trying to take their seatbelt off, the next strategy might be using a seatbelt buckle or a harness. So unless they're used to keep a person in a wheelchair who may slip out of it, they are considered restricted practices. Yes, it's illegal to drive a vehicle when someone in it does not have a seatbelt on, but the guidelines as they sit at the moment is that this is considered a restricted practice under policy. So that's something that we'll need to go through a panel. We'll talk about the panel later. The other thing that's considered restrictive is psychotropic PRN medication. So PRN means medication as required. Most people will take a painkiller like a Panadol or a Nurofen or something when they have a headache. You only take it when the headache's coming on or is there. That's PRN medication. So as opposed to medication that clients might be on every morning and every night, those are not part of the restricted practice guidelines. So there are any psychotropic medications are those that affect cognition, mood, arousal or behaviour. They're not considered restrictive when used to treat a diagnosed mental illness and were given on a routine basis. So if someone's given, say, Seroquel morning and night, it's not considered a restricted practice. However, the guidelines are interpretable. The most recent understanding that I had from the clinical governance unit of the Aging, Disability and Home Care who wrote the guidelines was that if someone is prescribed, let's say, Valium or a psychotropic medication for a manic episode, they're diagnosed with bipolar disorder or whatever medication they're prescribed, because the behaviour support practitioner and the staff need to administer that medication based on the appearance and presence of a set of symptoms, they have said that that should go through the panel. So even though it is prescribed for a diagnosed mental illness, it's not routine, and the staff are required to make a judgment call of some degree on when in that escalated behaviour and symptoms that additional medication needs to be given. So it's probably safe to, as behaviour support practitioners, to identify that as a restricted practice and give those guidelines. Those guidelines about when to give the medication really should be developed in consultation with the prescribing psychiatrist, because administering and prescribing medication is obviously their area of expertise. The other thing is that the templates for writing this procedure up from ADEC policy currently request that the psychologist, behaviour support practitioner, transcribe the name, dosage, a frequency of the medication. Under the Australian Psychological Society guidelines and legal guidelines about transcribing medication, Real Therapy Solutions practitioners are not to write the name of the medication and the dosage. This is not something we have expertise in. It is something that, if it is transcribed wrongly, has significant and serious implications, and there have been legal precedents outlining this should not happen. So this is one of those places where the policy is in direct conflict with the codes of conduct, standards and statements issued by our governing body, and also in this case with the law around transcribing medications. So Real Therapy Solutions practitioners are not to put the dosage and name of medications in. You need to refer to the medication chart, and you need to attach a copy of the medication chart to your plan. So that chart is written by the doctor, the psychiatrist, and therefore is safe to include. So psychotropic medication, if it's used as PRN, it's a restricted practice. You must not give after behaviour or crisis is over, obviously, and legal consent needs to be contained regardless of daily or PRN. So I'll talk about consent in a minute around all of these restricted practices. The other one is restricted access. It's preventing a person from access to certain items, objects, people, places, and which they have the right to access. So this one is, unless you're locking someone into a house, so you're locking the front door and the back door, or you're locking the front door and the side gates so that the person can't leave the premises, which is a breach of freedom of movement. Most of these are not governed by the law, in my understanding. So, for example, if a person is, apart from detenue, which I'll explain in a minute, if the kitchen is locked in a group home or a day service because a person has, behaviours that mean they overeat and put themselves at risk, there's no law around really locking that kitchen up. However, taking an object off someone that they own, so taking someone's iPad off that they purchased, it's their iPad, is considered something called detenue in eyes of the law. So whenever we're using a physical barrier to enforce boundaries or limits on a person, it's considered an environmental constraint or restrictive access. The policy, the ADDIC policy, also states that it must be beyond what is reasonably accepted in the community. There's that term, reasonably accepted. So I would consider, although I am no expert in this area, I would consider that it's reasonable to lock chemicals up in the community nowadays. Like, most places would have an issue, most families lock chemicals up and don't have free access to them. However, we have been told by the Clinical Governance Unit when they were in existence that locking chemicals up is considered a restricted practice. So when looking at this issue, most service providers will have a policy around work health safety that includes to lock chemicals up under WHS. Therefore, the service provider themselves can say that their decision is that they they don't need restricted practices for this. So this is something to consider with the service providers. Response cost, sorry, that's my phone going off. Response cost is, I love this little diagram where the person in the car is saying 60 miles an hour, but that's impossible. I've only been driving for 15 minutes. How can I have gone 60 miles an hour? Response cost, if any of you have ever had a speeding fine, a parking fine, or anything like that, you've been the recipient of response cost. It is taking or keeping something that belongs to the person they like or value as punishment for something that they've done wrong. So in the example I just gave, you've been fined, they've taken your money off you as punishment for speeding. There's no real correlation between those two things, and even if there were, it would still be considered consequence-driven practices or response cost. Things like withholding money, access to family, employment, food, shelter is not a restricted practice, it's prohibited. So probably the most common one that you may come across is people will say, look, you won't be able to see mum and dad this weekend. Mum and dad have said that you can't go home to see them this weekend unless you behave during the week. That's not a viable strategy to use to encourage and motivate someone to do the right thing. Access to their family and having that connection is really a basic right. So response cost is preventing someone from going on a scheduled outing because of their behaviour that is displayed the day before. So, no, John, you were hitting something or doing something yesterday, therefore you can't go bowling today. Or, John, if you don't stop, you won't be allowed to go bowling tomorrow. That's a restricted practice. The only time it isn't is whereby it is unsafe to take someone on an outing because of the behaviours they are displaying right now. So that would not necessarily be considered response cost, but when you've got a delayed reaction or a delayed consequence because of their behaviour, that is considered response cost. This is one that when you are supporting a person with an intellectual disability, it's quite common for staff not to be aware, or the carers not to be aware that this is actually a restricted practice, because it is a common strategy that we may use with children, and I won't go into in this training why sometimes it's okay to use it with children and not people with an intellectual disability, but there's a number of reasons, and one of them being the cognitive deficits and the learnings and the support and the nurturing and the caring that goes on around these behaviours are very different between children and often adults with an intellectual disability. Not to undermine the fact that adults are legally considered adults. Okay, so let's have a look at restricted practice. What are the key rules? They should only be used when other strategies have been tried and when time permits. for this. So, for example, you should be able to justify that less restrictive strategies have been trialled. It's the behaviour support practitioner's role to dig up this information, talk to carers, review files, and see what's been tried in the past that didn't work, that then justifies this more restrictive strategy or practice. They must be monitored and reviewed. So if someone's has physical restraint in their behaviour support plan and it's been approved and consented to, it needs to be documented when this physical restraint and how often it's being used, and it needs to be reviewed at least annually by somebody who is appropriately qualified, so a psychologist or behaviour support practitioner. It must be part of an overall behaviour support plan. You cannot put a restricted practice in place without a person having a proper behaviour support plan. Given that the amount of service that a person is provided with nowadays is governed by their funding as given to them by the NDIA, the National Disability Insurance Agency, this can be a little bit of an issue, but it's not something that we should compromise on. So at the very least, we should be spending whatever funding they have, with their consultation, of course, on justifying the need for more funding to get a good behaviour support plan with a functional assessment of behaviour in place, particularly for things like exclusion of timeout, physical restraint, seclusion, those kinds of things. There's nothing in writing in policy that says this, but I have always operated under the assumption that seatbelt buckles maybe not so much of an issue in regards to having a full behaviour support plan, and that's largely from a clinical capacity that if somebody's only behaviour is taking their seatbelt buckle off in the vehicle, they have no other behaviours, I don't really know what kind of behaviour support plan I could write around that. I do need to justify that we've tried other options without putting the person and the other people in the vehicle at risk. I also know that were I to move states to Victoria, that this is not considered a restricted practice. So there's some justification that it's reasonable here. However, in most cases, we need to put a behaviour support plan in place, or at least some really good strategies around it. You do require restricted practice authorisation approval. So part of the behaviour support practitioner's role is to consult and assess the need for restricted practices, and always talk to your supervisor if you're unsure about any of these. Develop very clear written guidelines about how to put the practice in place, almost a task analysis of dot by dot what the staff should do, and then present it to the restricted practice panel, who are the body that authorise these. Now, the restricted practice panel is a policy guideline from the ADDIC policy. How this will look in the new NDIA world, we're a little bit unsure about at the moment, but the old system continues to go through. So it's not the behaviour support practitioner's role to authorise. It's not the service provider's role to authorise alone. This is usually a decision made by a panel made up of somebody from the service that supports the person, so the day care, the day service, the group home, and somebody with a clinical background, behaviour support background. The restricted practice panel cannot override a guardian's objection, by the way. So the other area of authorisation is consent. So aside from just having authorisation for the practice, the authorisation is for the staff to actually put the practice in place. There also needs to be legal consent. So somebody needs to be saying, yes, I understand that you want to, physically restrain John by doing X, Y, and Z, and I sign off on that. Now, it either needs to be the person, their person responsible, or a legal guardian that consents to that. The only exception for that, and this is again policy from the ADDIC behaviour support policy, is restricted access, where the panel can consent as well, and that's because there's actually no legal pathway for anyone consenting for restricted access. As I mentioned earlier, it's not really covered by any legislation. So anyone who has a restricted practice must have a behaviour support plan. that includes a functional behaviour assessment, and the plan must have strategies in that aim to reduce the need to use the restricted practice. So we don't just put a restricted practice in place after doing all our assessment, justifying it and go, there it is, it's there for good. It needs to be reviewed, and we need to put plans in to aim to reduce the need for it. So if someone their behaviour function is anxiety, they're highly anxious and their behaviour is driven by that, then we need to be putting strategies in the behaviour support plan that address that anxiety, and evidence-based strategies that look at reducing their anxiety, so hopefully we won't need the restricted practice in the future. So as I mentioned, you need 2 authorisations: consent, the person responsible or a legal guardian, and an organisation authorisation, which is that panel. So this is the consent. The person may be able to consent themselves. They need to understand what they're consenting to. For behaviour support practitioners and psychologists, we run considerable training on capacity to consent in the group sessions within the first few months of you starting. So refer back to that group training and your individual supervision with your supervisor around how do we know if a person's consenting. Person responsible is someone in that person's life who may be making those decisions for them on more of an informal capacity, a legally appointed guardian who's appointed by the guardianship tribunal, and some cases may require Supreme Court authorisation. So they're things like invasive medical procedures or certain libido-reducing medications. The restricted practice panel is usually 3 people: a manager of a service, an independent person, and a behaviour support practitioner, and they decide whether it's okay for the staff to implement those strategies. They're not really going, yes, you can do that. They're saying, look, we can't see any other reason why, any other thing that you can do to manage the risk associated with this. They're looking to make sure there's a behaviour support plan in place, that the strategies are clinically viable. So they're sort of reviewing that behaviour support plan to a degree. So final consideration as we come to the end of the brief training, where restricted practices do occur, they should be the action of last resort. They need to be independently approved and monitored, and they need to be accompanied by a comprehensive behaviour support plan that reduces and ideally aims to eliminate the need for longer term restricted practices. Restricted practices should be time limited and subject to regular review, and they should be accompanied by strategies that promote positive alternatives. So that last line really ties into all of your positive behaviour support training, your PIF training, all of those functional analysis of behaviour training that you do when you first come on board Real Therapy Solutions. All right, thank you very much. If you can sign the record of training and make sure that it's given to your supervisor for signing, that you have been through and completed the training.